Hello guys, I am Dr. Ravindra Savarkar and I welcome you back to Med School. This is second part of the series Tachyarrhythmias. Topics covered in this video are atrial flutter, atrial fibrillation and multifocal atrial tachycardia. Atrial flutter is also called as micro-reentrant atrial tachycardia. There is micro-reentry circuit in right atrium, usually near tricuspid wall area. To know more about pathophysiology of reentry, please watch video on supraventricular tachycardia. Link for the same is given here. Micro-reentry circuit can also be formed around scar tissue in atrium. Impulses moves in loop in reentry circuit and send impulses in surrounding myocardium also. This micro-reentry circuit takes our SA node as pacemaker of the heart. Atrial rate is same as that of rate of impulse generation from reentry circuit, which is usually 240 to 400 beats per minute. As this circuit is usually located near tricuspid wall, atrial activation occurs in retrograde direction and vector is directed away from inferior leads. Hence, P wave is inverted in these leads, including lead 2, where rhythm of the ECG is usually evaluated. Imagine if all atrial impulses being conducted to ventricles. Ventricles beating at such high rate will not generate any cardiac output and person can die eventually. Here AV node comes to the rescue. AV node acts as a checkpoint due to its slow conduction and higher refractory period. That's why usually all atrial impulses are not conducted to ventricles. Rate of conduction is expressed in ratio like 4:1. As impulse is conducted through normal conduction pathway in ventricles, QRS complexes are narrow. Ventricular rate depends on rate of conduction through AV node. Rhythm is regular unless there is variable block through AV node. So, rhythm in atrial flutter look like this. Baseline is fluctuating and looks like tooth of a saw. Hence, it is also called as sawtooth appearance. If you recall, second degree AV block is also expressed in ratio, just like in atrial flutter. But there is a difference between the meaning of these ratios in both the cases. In this rhythm strip of second degree AV block, there is 4:1 block. Here this means out of 4 P waves, 1 is blocked at AV node. This rhythm strip of atrial flutter also have 4:1 block. But here this means out of 4 P wave, 1 is conducted through AV node. In this ECG, baseline is fluctuating with fast atrial rate. PP interval is 1 large box long. So, atrial rate is 300 divided by 1, that is 300 beats per minute. QRS complexes are also normal. So, this ECG represents atrial flutter. There is 1 QRS complex for 4 P waves. Hence, there is 4:1 AV block. RR interval is regular and 4 large boxes long. Hence, ventricular rate is 300 divided by 4, that is 75 beats per minute. Atrial fibrillation is a narrow complex tachycardia with irregular rhythm. There are numerous foci of impulse generation and atrial activation is chaotic. Impulses reaching at AV node when it is not in refractory period are conducted to ventricles. As impulses reaching AV node are irregular, conduction to ventricle is also irregular. Atrial fibrillation is usually associated with cardiac diseases where atrial abnormality is present. For example, mitral and tricuspid valve involvement, coronary artery disease, chronic hypertension, etc. Sometimes it is not associated with any underlying cardiac disorder. Such cases are called as lone or paroxysmal atrial fibrillation. There is single atrial focus in such cases. It has undulating baseline with irregular spikes due to very fast atrial impulses. These spikes are often referred as fibrillary waves. Sometimes amplitude of these waves is so low that baseline appears flat. Atrial rate ranges between 400 to 600 beats per minute. P waves are absent. QRS complexes are normal. Ventricular rate is irregular and depends upon refractoriness of AV node. P waves are absent in this ECG. There is irregular ventricular rhythm as there are varying RR intervals. QRS complexes appear normal. So this ECG is suggestive of atrial fibrillation. If baseline is observed closely, there are some spikes in the baseline, which are nothing but fibrillary waves. If you want to know how to calculate heart rate from the ECG when rhythm is irregular, as in this ECG, please watch Basics of ECG Part 3 and let me know heart rate in this ECG in comment section. Treatment of atrial flutter and atrial fibrillation is almost same with some minor differences. There are 4 principal objectives in treatment of atrial flutter and atrial fibrillation. If ventricular rate is very high, there won't be enough time for ventricular filling, which will lead to reduced cardiac output, which in turn will lead to hemodynamic instability. Hence, first objective of treatment is ventricular rate control. To achieve this objective, drug which increases refractoriness of AV node are used. Calcium channel blocker like diltiazem and verapamil have minimal effect on blood pressure. If there is mild hypotension or cardiac contractility is impaired, digoxin is drug of choice to reduce heart rate as it also improves cardiac contractility. When these arrhythmias are associated with hypertension, beta blocker are drug of choice. Atrial flutter and atrial fibrillation also occur in cases like thyrotoxicosis. Beta blockers are also useful in such cases where sympathetic system is overactive. Second objective is conversion to sinus rhythm. There are 2 modalities to achieve this objective: pharmacological and DC cardioversion. Choice between them depends on hemodynamic status. If patient is hemodynamically stable, pharmacological way is preferable. For atrial flutter, antiarrhythmic like dofetilide or ibutilide are given. For atrial fibrillation, amiodarone or flecainide are given. If patient is hemodynamically unstable, DC cardioversion is treatment of choice. Atrial flutter usually revert to sinus rhythm with lower power like 50 Joule, while atrial fibrillation require higher power up to 200 Joule. Third objective is to prevent further attack. When sinus rhythm is achieved, arrhythmia can be prevented with oral amiodarone treatment. When sinus rhythm is not achieved, aim of treatment is to prevent excessive ventricular rate. This can be achieved with oral diltiazem, verapamil, metoprolol or digoxin. Ablation therapy is useful in cases of atrial flutter and paroxysmal atrial fibrillation, as there is only one ectopic focus of impulse generation. Ablation therapy is not effective in typical atrial fibrillation, as there are multiple foci of impulse generation. In atrial flutter and especially in atrial fibrillation, atria does not contract properly, leading to sluggish blood flow, which in turn lead to increased risk of clot formation. This clot can dislodge from atria and can cause thromboembolic phenomenon in the form of stroke, myocardial infarction, mesenteric ischemia, etc. So, fourth objective of treatment is adequate anticoagulation. Vitamin K antagonists like warfarin or newer anticoagulant like rivaroxaban, dabigatran can be used. Multifocal atrial tachycardia is usually present in cases of decompensated COPD. It may occur in cases of pulmonary embolism and heart failure also. It is precipitated by the factors like hypoxia, theophylline toxicity, electrolyte abnormalities like hypomagnesemia and hypokalemia, pulmonary embolism, etc. There are multiple ectopic autonomic foci generating atrial impulses as in atrial fibrillation. However, atrial activation is much less chaotic than in atrial fibrillation. ECG findings in multifocal atrial tachycardia are irregular ventricular rhythm with rate more than 100 beats per minute, irregular PP, PR and RR intervals, 3 or more morphologically distinct P waves, presence of isoelectric baseline between P waves. Rhythm in MAT look like this. There are more than 3 different morphologies of P waves along with ventricular rate more than 100 beats per minute. PR, RR and PP intervals are irregular. There is isoelectric baseline between two P waves. Treatment of MAT primarily include management of underlying disorder, which is most commonly COPD. Treatment of triggering factors is also very important, like supplemental O2 therapy for hypoxia, correction of hypomagnesemia with IV magnesium sulfate, correction of hypokalemia with IV potassium chloride, and stopping theophylline or related drugs for treatment of toxicity. Ventricular rate can be controlled with calcium channel blocker like diltiazem or verapamil. Use of beta blocker in MAT is problematic as they cause bronchoconstriction, which will aggravate COPD. They are also contraindicated in acute heart failure, which can also be an underlying disorder for MAT. So beta blockers are used only when other treatment fails. Digoxin is also not effective in MAT. Termination of arrhythmia can be achieved with amiodarone. However, cardioversion is not effective in MAT. This arrhythmia is self-limiting and disappearing with treatment of underlying condition, so rarely require long-term preventive therapy. Thank you for watching this video till the end. If you have any query or suggestion, please write it down in comment section. If you like my work, please like this video and share it with your friends. To get notified about next video upload, please subscribe to the channel and hit the bell icon. Till next video, take care and keep learning.